So welcome guys to another series on the bones of the upper limb. So we have talked about the clavicle, we have talked about the scapula, so now we are talking about the humerus. So now, what is the humerus? You are seeing it on your screen, very important. The humerus is a long bone. It's a horizontal long bone, not like the shoulder blade. It is not flat and triangular, but this one is just like a long bone, just like the clavicle. But this one is more longer, so it is the longest and the strongest bone of the upper limb. The longest and the strongest bone of the upper lip, and it is what homologous, which is just like it is mimicking the what femur in the lower limb. It is homologous to it. So the humerus is homologous to the femur of the lower limb. So same as the femur is the longest bone of the body and also the strongest, but now the humerus is the longest and strongest of the upper limb. So now looking at it now, how can we demarcate? What are the parts of the humerus? How can we demarcate it now? The humerus can be divided into three parts. You have the upper part, you have the shaft, and you have the lower part. So it's a very long bone, so you can see it. You have the upper part, you have the shaft, and you have the what? Lower part. Or you can call it the lower end, upper end, and the shaft. So look at it very well. So follow me small. Very important. Now in the upper part, or you have the upper end, you have the head, you have the neck, you have the greater tubercle, you have the lesser tubercle, and you have the intertubercular sulcus. Intertubercle, in between the two tubercle, which is the greater and the lesser tubercle. You can otherwise call the bicipital groove. Don't forget. So you can call intertubercular sulcus bicipital groove. So we have talked about the head, the neck, greater and lesser tubercle, and the intertubercular sulcus or bicipital groove. Now for the lower end, what can you see? The lower end, the lower end contains what? You have the capitulum. Now the capitulum is where the radius bone is attaching to. You have the trochlea, where the ulnar bone is attaching to. You have the radial fossa, you have the coronoid fossa, you have the medial epicondyle, which is very prominent. So it's on the medial side. You can see it when you flex your so when you flex your elbow joint, you can see it. It is the most prominent epicondyle in the what of the humerus. So you have your lateral epicondyle, which is not more prominent. The medial epicondyle is more prominent than the lateral epicondyle, and you have the ollacrinoid what process. The ollacrinoid process is just like a hinge of a door that enters into the what? The fossa. So this is the fossa. The ollacrinoid process is of the humerus that enters into the fossa. So get it. You have the capitulum. You see there. You have the trochlea. You have the radial fossa, you have the coronoid process, you have the medial and lateral epicondyle, and you have the ollacrinoid what? Fossa. Don't forget. Why the shaft is where the upper and lower end meets. So you can see the bone. Just follow me small as I talked about each of them one after the other. Now, going to the first one, the head. Now what can you say about the head? It is smooth and round. So if you are feeling it now, maybe you have the bone now. If you are feeling it, you know it is smooth and round, and it's 1/3 of a sphere. So it is a half sphere. It's not a complete circular object or a circular part. It is half of a sphere, just hemispherical. It's entering into the glenoid cavity of the scapula. It is entering into the glenoid cavity of the scapula. So we talked about the glenoid cavity at the lateral angle of the scapula. So when it enters into the glenoid cavity of the scapula, it is deepened by the glenoid lambrel. Don't forget, the head of the humerus is hemispherical, entering into the glenoid cavity of the scapula and get deepened by the lambrel, which is a fibrocartilaginous ring. Get deepened by fibrocartilaginous ring, articulating with it to form a glenohumeral joint. Don't forget, glenohumeral joint. So it forms a hyaline cartilage. That's why I said that part of it is formed by what we call endochondral ossification. So it's lined by hyaline cartilage into the glenoid cavity, forming a shoulder joint, or you call it the glenohumeral joint. Now we have talked about the head. Smooth, round, hemispherical, enters into the glenoid cavity. You are seeing it on your screen, or if you can palpate it, or if you can see it, it will be much more better. Now the next one is the neck. What can you see about the neck? Now in the neck region, you have different types of the neck. You have the anatomical neck, you have the surgical neck, and you have the morphological neck. But in some parts you can see the anatomical neck and the surgical neck. So That's what you can see. So what is the most important part about this neck? What is most important? The first one you can see is the anatomical neck. The anatomical neck is where the capsule of the shoulder joint extend to. Don't forget, the capsule of the shoulder joint ends at that particular part, at the anatomical neck. When the glehnut cavity is covering the head of the humerus, it's covering up to the anatomical neck. And also the capsular ligament is also attaching here. Where's the capsular ligament? The capsular ligament is covering the fibrous capsule, which is a covering or an external fibrous sheet that is covering the shoulder or the glenohumeral joint. Don't forget. Also very, very important, the capsule is deficient because of there's a passage of the long head of the biceps. The capsule is deficiently superiorly around the anatomical neck, where the long head of bicep transverse. Don't forget. So this is the anatomical neck. The anatomical neck is the constituted part of the head of the humerus, and it marks the region where the capsule of the shoulder or the glenohumeral joint attaches to. Don't forget. Now the surgical neck is a short constricted part of the upper end of the humerus. Is the constricted part in the upper end, so it is not like the anatomical neck. It is more lower. You are seeing it on your screen. It is much more lower. In the anatomical neck, the capsule of the shoulder joint is attaching there, but the surgical neck, no, it is just below the greater and lesser tubercle, just below it. So you see it there. Are you getting it now? So when you see it there, that is the anatomical neck. The only problem is that it usually fractured most times. What about the surgical neck? Is a short constricted part of the upper limb, just above the shaft and below the greater and lesser tubercle. So you see it below the greater and lesser tubercle, but the anatomical neck is just some centimeter away from the head. So the capsule of the shoulder joint extends and attaches to the anatomical neck. So the head of the humerus is intracapsular down to the anatomical neck, but the surgical neck is not. It's a short constricted part, but below the greater and lesser tubercle. And one is related to the axillary nerve and the posterior and anterior circumflex humeral vessel. You get it now? So it's an important feature for surgeons. So when surgeons is working on the axilla, they have to take note on the surgical neck. They have to take note on surgical neck, because in the surgical neck the axillary nerve is there, and the posterior and the anterior circumflex humeral vessel, just below the greater and lesser tubercle and above the shaft. Don't forget it. Get it now? So again, there is always the surgical neck fracture and damaging of the surgical neck, because it's not that strong. The surgical neck is not that strong, so it can fracture easily. In the morphological neck, because we're talking about the anatomical neck, we talked about the surgical neck, now we're talking about the morphological neck. The morphological neck is the junction between the epiphysis and the diaphysis. That junction, the epiphysis is at the ends of the bone, while the diaphysis is in the shaft of the bone. So the junction between the epiphysis and the diaphysis, and it is a true junction of the head with the shaft. It's a true junction of the head with the shaft, and it's representing the epiphyseal line of the adult bone. What is the epiphyseal line? The epiphyseal line is that line where the bone grows. You get it now? But in adult, the bone is already fused, so there's no need. There's no epiphyseal plate where the bone can grow from. You get it now? So that is the morphological neck. So very, very easy. Anatomical neck, the joint. Anatomical neck, the capsule of the joint extended. Surgical neck related to the axillary nerve and the circumflex or humeral vessels, and also is very weak and is prone to fracture. Now the greater tubercle, you can also see it. The greater tubercle is the most prominent part of the upper part of the humerus. It's very, very prominent. You can also palpate it. Very, very important. Now the greater tubercle, now it marks the attachment of the seat muscle. What is the seat muscle? The muscles of the rotator cuff. So we can call it the rotator cuff muscle. So take it one step at a time. It's very prominent in the upper part of the humerus, and it marks the attachment for the seat muscle, which is muscles of the rotator cuff, or you call it the rotator cuff muscles. So we have the supraspinatus, infraspinatus, and teres minor. But this subscapularis do not insert on the greater tubercle. It's insert on the lesser tubercle. Don't forget, the lesser tubercle is just a little above the surgical neck. So you can see just a little above the surgical neck, but it is slanted down when you see the greater tubercle. When you slant the greater tubercle down, you see the lesser tubercle. The greater tubercle is the pointy part of the upper part of the humerus. So if you slant it down, you see the lesser tubercle just above the surgical neck. Now the intertubercular sulcus, or they call it the bicipital groove, is just a region between the greater and the lesser tubercle. So that hole between the greater tubercle that you are seeing, that hole between the greater and lesser tubercle, is called the intertubercular sulcus. You get it now? In the intertubercular sulcus, you have three parts for the attachment of three basic muscles. We call it the lady in between the two major. The lady in between the two major. There's an L in between the two mm, which is 2m and 1l in the middle. 2l and 1 n in the middle. So number one, the 2m, now in the intertubercular sulcus or the bicipital groove, you have the medial lip and you have the lateral lip and you have the floor. You have the medial lip, you have the lateral lip, and you have the floor. Again, the intertubercular sulcus is in between the greater and the lesser tubercle, and inside there you have the medial lip and you have the lateral lip. In the medial lip is marked for the insertion of the teres major. So the lady L in between the two major. The medial part now is the insertion of the teres major. In the lateral part is for the insertion of the pectoralis major. So lateral lip for pectoralis major, medial lip for the teres major. While the floor, which is the middle part, which is the lady, is the latissimus dorsi. Don't forget. So hope you are getting it one after the other. Now in the shaft, what can you see? In the shaft, if you look down the bone, what can you see? You can see the what? The radii groove. So I'm just giving you so it will be much more easier for you. You can see the radii groove there. The radii groove is where the radii nerve pass through. So you can call it the radii groove. So the radii groove is where the radii nerve pass through, because when there's fracture of the shaft of the humerus, what happens? You are damaging the radii groove. So also important. You also have the deltoid tubercle. So the deltoid tubercle is where the deltoid is inserting to. So you have the deltoid tubercle, or you call it the deltoid tuberosity. You can see it in the anterolateral surface of the shaft of the humerus. The anterolateral surface of the shaft of the humerus. While you can see a spiral or a radii groove where the radii nerve passes through. So fracture of the shaft of the humerus causes what? Radii nerve to be damaged, so which is also not good. So in the anterolateral surface you have the deltoid tuberosity, where the deltoid muscle inserting. You get it now? Also in the posterior part, you can also put down, there's a part whereby in the posterior, just about that radii groove, you can see where the origination of the brachialis muscle is. I can see various, there are so many things. The brachialis muscle is originating there. Also the medial lateral part of the triceps also is originating from there too, just in the radii groove. But now in below the radii groove, in the posterior surface, that is where the triceps is originating from, which is the medial and lateral part of the triceps is originating below the radii groove, or you can call it the spiral groove. While above the radial or spiral groove, that is where the coracobrachialis is what? Inserting to. The coracobrachialis is inserting to, don't forget. And also the brachialis muscle is also originating from. So don't forget. Below the radii groove, the triceps is originating, while above the radii groove, the coracobrachialis is also what? Originating from there. So just look at it. You can see it. Remember, red is for origination, blue is for insertion. Now in the lower end, now what did I say? You can see the capitulum. Don't forget, you can see the capitulum. So in the capitulum now, the capitulum is articulating now, or you can see it is articulating with the head of the radius. So if you put the humerus, the lower part of the humerus bone on the ulnar and radius, the capitulum is articulating with the head of the what? Humerus. The trochlea is just like a pulley shape. It's a pulley system which articulates with the trochlea notch of the ulnar. In the lower end now, we have talked about the upper end, which is the head, the neck, the greater lesser tubercle, and the what? Intertubercular sulcus. We have talked about the shaft, where I noted the radii groove, I noted the deltoid tubercle, I noted the origin from the brachialis, coracobrachialis, and below the radial group, the medial lateral part of the triceps, because the long head of the triceps is originating from the infraglenoid tubercle. But now in the lower end, I talked about the capitulum articulating with the head of the radius, the trochlea articulating with the trochlear notch of the ulnar. You can see it. Now, also in the now you have the epicondyle. So the one that is shooting out, the most prominent part for your exam, the most prominent part in the lower end of the humerus is called the epicondyle. So if you straighten your hand, or if you flex your hand a little, flex your elbow joint a little, you'll be seeing the medial epicondyle. It is more prominent than the lateral epicondyle. So the ulnar nerve for your exam, the ulnar nerve passes at the posterior surface of the medial epicondyle. Again, you can palpate your ulnar nerve in the posterior surface of the medial epicondyle in a place called the cubital groove. You get it? You call the cubital tunnel or the cubital groove. So if you hold your cubital tunnel at the back of your medial epicondyle, what happens? You are palpating your ulnar, and if you hold it for a long time, you will not be able to feel your lateral, you will not be able to feel your medial aspect of your arm. And also that medial epicondyle is very, very important too, because that is where the common flexus origin for the anterior compartment of the forearm. That medial epicondyle is marked for the origin of the flexor muscle of the wrist joint, which is the muscles of the anterior compartment of the forearm, while the lateral epicondyle marks the origin for the common extensor origin, which is muscles of the posterior compartment of the forearm. Now, before you see the epicondyle, you see the supracondylar ridge, medial supracondylar ridge and lateral supracondylar ridge. Don't forget, you have your medial supracondylar ridge and you have your lateral supracondylar ridge. Your medial supracondylar ridge is very, very important, and your lateral supracondylar ridge, that is where your brachioradialis muscle is coming from, and the extensor carpi radialis longus also is coming from this lateral supracondylar ridge. Because damage or fracture, because I say the one, you have surgical neck fracture, you have the shaft fracture which damages the radial nerve, and you have the supracondylar fracture. And don't forget, so the fracture is usually at the three parts. Very, very important. So I've listed, but you have surgical neck fracture, you have the shaft fracture, and you have the supracondylar fracture. So if you damage your supracondylar, what happens? Some muscles that are originating from there will also be damaged. And I said the most prominent part is the medial epicondyle, not the lateral epicondyle. So the lateral epicondyle is not prominent. And also, if you damage your medial epicondyle, which is you are damaging your ulnar nerve, so you can also call there's what they call cubital tunnel syndrome. Don't forget. Now, if you look at the lower end, in front of the lower end, what are you seeing? So look at the lower end very well. If you are looking at the front of the lower end, what are you seeing? So you are seeing a hole there. What is the hole called? It's called the coronoid fossa. The coronoid fossa, which is above the trochlea, and you have the radial fossa, which is above the capitulum. So the coronoid fossa is where the coronoid process enters into. Are you getting now? The coronoid process enters. The coronoid process is of the ulnar. Now you now have the head of the radius. When it fits into the capitulum, it also interacts with the radial fossa. So when you flex it, when you flex the elbow, you can also see your radial and the coronoid fossa. Don't forget. So now at the back, now you can see one hole. In the front, you can see two holes, which is coronoid and the radial fossa. While at the back, you can see one hole. What is the hole? The hole is the olecranon fossa. The olecranon fossa. Now the olecranon process enters into the olecranon fossa. So it's just like a hinge. So the hinge you see on the door, where you can open the door and close it, so that is the same hinge. So when it enters, so when you extend your elbow, the olecranon process enters in fully into the olecranon fossa. Are you getting now? At this particular point, when you extend your hand, both the two epicondyle is in the same line as the olecranon bowl. Are you getting now? But when you flex your elbow, flexing your elbow is bringing your elbow towards your jaw. When you bring your hand, like your fingers, towards your jaw, you are flexing your elbow. And when you flex your elbow, what happens now? It's not different. Your olecranon fossa is not inside the Now when you flex your elbow, the olecranon process is not inside the olecranon fossa, so it is forming a right angle, or is forming a triangle with the medial and lateral epicondyle. So don't forget, when you extend, like when you extend your elbow, what happens? Your olecranon process is in the same line as the medial and lateral epicondyle, but when you flex it by bringing it towards your mouth, what happens? It forms a right angle with the medial and lateral epicondyle. So that is very, very important for your exam. It will be important. Now what can you do? Now you can have fracture. What fracture did I say you can have? You can have surgical neck fracture, where you damage the radial nerve and the circumflex humeral vessels. Why, if you have humeral chaff fracture, what happens? You are damaging your radial nerve. In humeral chaff fracture, you are damaging the radial nerve at the radial groove. Why in supracondylar fracture? In supracondylar fracture, you can also call it Volkmann ischemic contracture. Volkmann ischemic contracture. In that supracondylar fracture, who are you damaging? You are damaging the brachial artery. You are damaging the brachial artery, and sometimes you can also damage the median nerve. Now Volkmann ischemic contracture, which you call the supracondylar fracture. In supracondylar fracture, it can also be caused by the Volkmann ischemic contracture, whereby you are damaging your brachial artery and your median nerve. Are you getting that? Why in surgical neck fracture, you are damaging the axillary nerve and the posterior and anterior circumflex humeral vessel. Why in the humeral chaff fracture, you are damaging the radial nerve. Do you get it? Very, very easy. Now the next one is the ossification of the humerus. So just like the scapula, it's ossifying with 8 centers. 8 centers, but 1 primary center and 7 secondary center. While the scapula is also 1 primary center and 7 secondary center. 1 primary center in the body and 7 secondary center scattered all around the bones of the scapula. But for a humerus, now you have 1 primary center in the shaft, while 7 secondary centers scattered all over. 4 is present in the lower end, 3 is present in the upper end. Don't forget. Now 1 present in the shaft. So when is the ossification in the shaft? It's coming 8 weeks. 8 weeks. Also the scapula is also 8 weeks, while the clavicle is 5 to 6 weeks. Don't forget. But now in the secondary center ossification, it can ossify in different times. So you might know it, you might not know it. It might be important, it might not be important. You get? Because in the upper end, it's located in the head, greater tubercle and lesser tubercle. You can use the first year for the head, 3rd year for the greater tubercle, and 5th year for the lesser tubercle. And they both fuse in the 20th year. Why the lower end, you can see the 2nd year, 10th year, and the 12th year. For the capitulum, medial part of the trochlea, lateral and medial epicondyle. So in case, just know the primary center ossification at 8 weeks. So I hope it all made sense to you and you have understood everything I've talked about in the humerus. So you understood everything when we talk about what humerus is, homologous to the femur of the lower limb, the strongest and the largest and strongest bone of the upper limb, and very, very important, is articulating with the ulnar and radius lower and with the glenous cavity of the scapula in the upper part, forming a glenohumeral joint. We talked about the upper end, which is the greater tubercle, lesser tubercle, intertubercular, head, and neck. We have the shaft in the middle, and the lower end, the capitulum, and everything. So I hope you all understand. Very, very important. Very, very simple. So check the bones. I put it there. Very, very simple. So look at the bone, try to get it, because when you enter the muscles of the upper limb, you'll be seeing all these things, attachment, originating. So look at the bone, look at it, look at the muscle, blue for insertion, red for origination. So understand it, don't forget it. So now continue liking, sharing my videos at every point in time. Anytime you see my video, like and share it to your friends. It's very, very important, because I'm bringing out the part you need for your examination. So I'll be seeing my next video on anatomy on the radius bone. Bye bye.